Good morning, good afternoon, and good day to everyone joining us today. Welcome to our SRH Global Webinar. Today we're going to have a great discussion with great speakers lined up. We're going to present on contraceptive implants, and we're going to hear from different perspectives. We're going to see from the global perspectives where we are on programmatic areas, and we will also be presenting and hearing about where we are when it comes to localization and removal of contraceptive implants. The first presenter that we are going to have today is going to be Dr. Mark. He's going to take us into the programmatic and health systems perspective. And this section is going to be discussing about access, uptake, and supply, and service delivery of contraceptive implants. When we hear about the contraceptive implants in here, we're going to have a presentation on the discussion of the global and regional trends in the uptake of implants. Who are the users when it comes to the demography? So Dr. Mark, who is a board-certified OBGYN, who is a medical doctor and public health specialist, and he's currently serving as a family planning and reproductive health senior and technical advisor at JAPICO. And he has been a medical director and at CARFM since its inception in October 2014, and provided medical services to Planned Parenthood, Metropolitan Washington University at the Washington and Unity Healthcare in Washington. He has been serving, and he has served on several national level working groups and committees, including the Institution of Medicine Standing Committee of Family Planning and National Contraceptive Metrics Group. He holds an appointment at Johns Hopkins University and the National Contraceptive Metrics at the Johns Hopkins University at the Department of OBGYNs and Science. He served on the board as a board of directors of the National Family Planning and Reproductive Health Associates and Association of Reproductive Health Professionals, and now is a Population Council, Population Connection. Dr. Headway is a dedicated advocate, and he has been interested in advancing reproductive health policies, family planning strategies, and the development of sound public health policies. He began his OBGYN career earlier, and he started with Washington Hospital Center as an OBGYN faculty from 1997 to 2013 in Washington, D.C. There, he developed and led sections of community outreach and the family planning section, and also the residency program at Ryan and the family planning fellowship. We are so delighted to have him in this SRH webinar series. And our second speaker is going to be Sarah Prager. And Dr. Sarah Prager is going to take us into the clinical aspect of contraceptive implants. And Dr. Sarah Prager is a professor in the University of Washington at the Department of Obstetrics and Gynecology. And she is an adjunct professor of health services at the University of Washington School of Public Health. And she is the director of Family Planning Division and Fellowship in Complex Family Planning. She teaches family planning medical students, residents, fellows, and allied health professionals. She has over 15 publications and peer-reviewed journals, and has been co-author in 5 chapters and also 6 up-to-date topics. Dr. Prager has been part of the working group in the updates of the CDC medical eligibility criteria on contraceptives use and selective practice recommendations, and she has also an extensive experience of working with ACOG and other national and international organizations since 2001, and she has been a co-chair of the Abortion Access and Training Working Group Secretary of the District 8 starting from October this year, and since 2009 she has also participated in global family planning projects, and she has been into different countries including Nepal, Pakistan, Uganda, Zambia, the country Ethiopia here, Zimbabwe, and she spent an academic career starting from 2009 to 2020 while the pandemic was really hitting the globe, and she has been in here at her sabbatical from the University of Washington, and has been serving and still serving as part of a faculty as an OBGYN department of St. Paul's Hospital Millennium Medical College in Addis Ababa, Ethiopia. And her specific focus in Ethiopia is supporting and growing the family planning fellowship program in the country, which is one of the the new family planning programs in the region. And Dr. Prager has received her undergraduate degree not only in just medicine, but also in Roman language and literature from Princeton University in 1993. She received her medical degree in the University of Texas and has been teaching residency programs, and also did her fellowship and clinical research from the University of California, San Francisco. She has been a faculty at both the University of Washington since August 2006, and also a faculty at St. Paul's Hospital, Millennium Medical College in Ethiopia since September 2019. So we're very delighted to have Professor Sarah Prager with us in this webinar series today. And our third speaker is going to be Dr. Farid Abubakar. Dr. Farid is an OBGYN and an associate professor, and he's also a clinician, has been a researcher, has lots of experience working on global programs and family planning issues. He's a family planning subspecialist and RX subspecialist. And he has been serving in different positions, including serving as a fellowship lead, and also has been practicing in different international organizations previously, and also at different times at the World Health Organization. We're very delighted to have him as a teacher who has been teaching residents, medical students, interns, and other allied healthcare professionals. He has several publications now at the international peer-reviewed journals, and has been taking part in national and international organizations, including the Ethiopian Society of OBGYNs, and also a technical working group for the National Technical Working Group at Family Planning, and Abortion Technical Group of the Ethiopian Ministry of Health, and has been serving as a peer educator and also teaching residents and family planning fellows at different times in Ethiopia. We're so delighted to have him, and Dr. Farid Abubakar is going to take us into the different difficult removals and different implants, where localization and removals of non-palpable implants. So we're so delighted to have him with us in this webinar series. So we're going to start with Dr. Mark, and Dr. Mark, over to you with the first presentation.
Good afternoon, good evening, good morning to all of you. Thank you so much for joining us today. My name is Mark Hathaway, and I'm going to talk about the rise of implant use in the global context and how it illustrates some programmatic considerations. I am thrilled to be speaking with you all. I love this opportunity. I should point out that my expertise is more in terms of clinical guidance, clinical use of implants and other contraceptive methods, insertions, removals, training of trainers, etc. However, I am presenting today some wonderful information that's been collected by colleagues across the globe over several years. And thanks to my current JPIGO colleagues, Megan Christofeld and Brittany Ehlers, who's helped me put together some slides to talk about this. Again, I'm hoping that some of the folks on the line will be able to weigh in when needed and clarify some issues if I don't cover them completely. These are some of the talking points. Very, very brief history of the implants and methods that are currently available across the globe. I'm going to speak on some global and regional trends in implant uptake, and again, a very broad view of that. I'm going to speak briefly about the volume guarantee and how that has aided in use across the globe of implants. I have a slide showing the public sector costs of available methods. We'll talk a little bit about the procurement data and its ramifications. And that will be towards the end of the presentation. I'm going to also talk about method mix, and I have that in quotes. I'll explain that a little bit in detail later. And who are the users? And the brief take on who are the users across the globe, it's basically anyone who is interested in a contraceptive method that might help them avoid or will help them avoid a pregnancy or space of pregnancy. and who can provide implant insertions. I'll touch briefly on that, as well as who can remove implants. And a lot of that information comes from what we know, the WHO's task sharing work that they've done over several years. And then many colleagues have thought long and hard about removals. And now that we're having many, many more implants in arms, are we doing a good job of helping them get out of the arms when a woman wants to become pregnant or wants them removed? And then I've got some tips for success in terms of removal access. So the brief history of implants. The first implant was developed by the Population Council in about, I think, 1983 to be the exact date. It was introduced in the Dominican Republic in 1986, and in Indonesia in 1987. The initial uptake was fairly low, as you might imagine, for a new method, roughly 0.1% in the Dominican Republic and 0.4%. And then by 1991, the implant use started to climb a bit. Indonesia had a slow expansion with almost 3%. But no other country was above that 1% level roughly until Haiti hit that in the 2000s. The level of implant use increased slowly into 2010s, the first decade of 2000. And you can see a couple of examples here: Tanzania, Kenya, Zambia, Malawi. But the global use began to increase rapidly in 2012, and I'll explain that in a few minutes. These are the methods that are currently available across the globe, and Dr. Sarah will talk more in depth about these methods. She's going to talk about mechanisms of action, contraindications, their hormones, etc. But I just want to point out that there's basically 3 implants across the globe. One is the Merck now Organon's Implanon NXT, a 1-rod system. There's the Levoplant, which is Shanghai Dao, the 2-rod system with levonorgestrel, and then the Jadel, the 2-rod system by Bayer. And those 3 methods are available globally. And you'll notice down here at the bottom, the prices. We'll talk about that in a little bit. This is some wonderful work done by Dr. Roy Jacobstein, who looked at DHS data from many, many different countries and put them onto a graph. And you could see this demonstrates this uptake, which has occurred over the last probably now about 20 or 10 years or so. And it's climbing quite steadily. That's a wonderful thing in many regards. It also has some ramifications that I'll touch on in a little bit. But the reason for this uptake is several-fold, and we'll talk about that in a minute. The percentage of married women using implants, and this is a very, very, very sketchy and global look of implant uptake. And you'll notice that in the different shades of the colors across the bottom, you can see the bars, the redder, or the more maroon or darker colored red. That's where the uptake is the highest. And then the red is slightly below that. And then the kind of the lightest color is where there's very little uptake or low percentage of uptake of implants. And these are married women. This is DHS data. And it's not a perfect look, but it gives it kind of an idea where use is occurring. I'm going to touch on what's called the implants volume guarantee or volume guarantees. And it's not, again, my area of expertise, but I'm going to focus mainly on this second component here in the middle, the solution. So implants were becoming readily available in various countries with a fairly high cost to public sector, to governments. And so in roughly around 2012, excuse me, there was a volume guarantee that was developed with the Bill and Melinda Gates Foundation offering a guarantee initially to Merck and to Bayer, 2 of the manufacturers at that time. that over 6 years, the sales volume of implants in low and middle income countries would be roughly double. And this volume commitment was secured by a huge grant donors from Bill and Melinda Gates Foundation, Norway, Sweden. You can read the others. And in return, Bayer and Merck agreed to offer their implants at roughly 50% of a reduction in cost, or $8.50. Prior to that, it was somewhere in the neighborhood of about $15. And their guarantee was that they would procure, the governments would, with the donors' dollars, would procure 27 million units through 2018. A fantastic thing that happened. That was a fantastic step forward in terms of implant uptake across the globe. And I'll point out later that that has some ramifications, but really tremendous in terms of improving access. These are the three implants that are available across the globe with their respective costs, or the costs down below. The Shanghai Dawa Levoplant is slightly lower in price. That's distributed by DKT. And then the others you can see here, Implanon NXT and Jadel have a similar price point. And these are the actual costs for governments to procure these methods for the different governments across the globe. I'm going to talk about method mix, and method mix is as a wonderful way of looking at users in different countries or within a country or within a region, but it's not without its what's the word? It's not without its issues. So method mix doesn't measure unmet need, for example. So you could be looking at a country's use of methods, but they may have an incredibly high unmet need. And so it's only looking at those that are using modern contraceptive methods and the percentage of different users. It doesn't get down to the nitty-gritty of differences across regions within a country, or it doesn't get down to the nitty-gritty of potential coercion, perhaps if one method is being pushed more than other methods. It doesn't touch on all of the issues, but it does give some really, really great information about differences. So I have 4 countries that we're just going to look at very, very briefly. And you'll notice to focus on the yellow. The yellow is where the implants, the implant method mix, or the implant percentage in this country, our host country, Ethiopia, on the left, Pakistan on the right, it's 1.6. So you can see a very tremendous difference. But again, this is percentage of modern contraceptive users. And, this could be in Pakistan, for example, it might be 1,000 implants. And in Ethiopia, it might be a much, much higher number, or vice versa. So this is a percentage. It doesn't necessarily show you the numbers of procured devices or the numbers. This is percentage again. Here's another look at 2 other countries, Ghana and Indonesia on the left. And again, focus on the yellow, which is the implant use of modern contraceptive users. This is fantastic information collected from the DHS, and we've had much, much better data these last several years than we've had in the past, which is really, really great in many, many, many regards. The typical user, who is the typical user of implants across the globe? And it's just about anybody. There's huge variances in different users, and it has a lot to do with many, many different aspects, but basically anyone could use an implant. There's very, very few contraindications, as Dr. Sarah will point out. And there's many, many, many factors that go into the use in various countries and various regions within countries. So the socio-demographic differences are huge. The economic differences are huge. Reproductive characteristics, they all vary tremendously within a country, from country to country, across cultural contexts, by providers. So you may have some providers have some biases towards or for or against implants, for example. Health systems may be an issue. There may be more access in the private sector versus public sector, or vice versa. So many factors go into who's a typical user. And one of my colleagues years ago said to me, think about the multiple P's, Mark, the multiple P's. There's the policymakers who have an impact, the providers, the public perceptions or misperceptions, the promotional, the media, the propaganda that may be done, the patients' perceptions, the procurements, and that includes, stockouts, whether there's methods are available, could do many different factors. The short of it is, typical user could be anyone, but the tremendous variance, and it has to do with all those other factors. So I'm using Ethiopia as a quick snapshot, partially because they're our host country, but partially we have some pretty good data. So you look here in the left graph, you can see that the education levels vary. So this is the light blue is married women, and the darker blue is unmarried women. And then we also have put that together with with education levels. So there's big differences in education levels, big differences in married and unmarried women. On the right, you can see not a big difference in urban users versus rural users across Ethiopia. Then we look at regional differences, and within Ethiopia, you can see the darker red is where there's a higher uptake of contraceptive implant use, and then the lighter yellow is where there's a lower uptake. So again, this is within a country, we can see there's vast regional differences, and that has to do with many different factors. How the expansion occurred. Ethiopia is a great case in point in that they have utilized healthcare workers to provide implants across the country. A great strategy to improve uptake and access. And I believe that was some work done by Pathfinder several years ago. We won't touch on that chart on the right. So who can insert and remove implants? And this is where the WHO information is really helpful to think about task sharing. And several years ago, they looked long and hard at different cadres of providers that could and should have the skills to place any contraceptive method or utilize any contraceptive method. And they looked at various cadres. They looked at how to expand use, all with the notion of trying to improve access to contraceptive methods by improving task sharing or increasing utilization. They looked at cost effectiveness of different cadres of providers, and very helpful to what is many of our goals to reduce unmet need across the globe. This is kind of a summary of their work that they did. And if you look, focusing in here on implant insertion and removal, you can see that pharmacy workers, pharmacists are not good for placing implants or removing implants, but auxiliary nurses, auxiliary nurse midwives, for sure could be placing implants and removing implants. Nurses, midwives, etc., all the way down to the far right, where you have specialized doctors. And then here you'll notice that in the yellow, these are recommended in the context of rigorous research. So again, in the case of Ethiopia, my understanding is that healthcare workers, health extension workers, were trained on insertion of implants, which is really fantastic. And that has a lot to do with why the increased use of implants has occurred in Ethiopia to a large degree. Then, as I pointed out very early on, one of the things that we were aware of happening as uptake happened is that the ramifications for that are somewhat considerable. And you'll notice as procurements increased, so again, this is a procurement chart, not usage necessarily, but it's a procurement. So we've noticed that there's been a large climb or a quick climb of use, I'm sorry, of procurements across the globe, but that is not without its problems or potential problems. So we've been noticing over several years that women are having tougher times getting their implants removed. And this kind of just is a model or projecting how those removals perhaps lag behind insertions, of course, but how that could be problematic. And we know now from some research that was done, some data from PMA about implant users. This is just a quick look, a couple of 3 countries, that certain number of users are having trouble getting their implants removed for a host of lots of reasons. This task force the implant removal task force looked long and hard, placing the implant user in the center, and what are some of the issues that are needed and considerations and conditions that are needed to provide quality implant removal. And they are things like making sure you have all of the supplies needed, making sure you're collecting the data, making sure that the service is affordable or free. So a woman shouldn't be charged extra money to have an implant removed if she's coming into the public sector. So it shouldn't be too far away. She shouldn't have to travel long distances, et cetera. So these are just some of the considerations to think about as implants are being placed, and then making sure that we're also keeping an eye on implant removal. Dr. Ferrer is going to talk a lot about the trickier removals, but again, focusing on if the insertion is done properly, removal is much, much easier. So we need to make sure that we're training and perhaps even doing refresher trainings in quality insertions. Providers need to be trained on both standard and difficult removals. There needs to be referral systems. So these are just some tips. Actually, there's 11 tips here, but they're tips for expanding access to quality implant. And this comes again from the work from the implant removal access group or task force. Many colleagues from nonprofit sector, from public sector, and institutions, non-governmental organizations across the globe came together to think about. This is a very quick look at one of the resources of the many that are available in a piece that I'm going to show you in a second. This is an implant standard removal. Up in the far right, you can see some of the equipment that's needed. So making sure you have all of that equipment available. If you're going to be doing removals, this shows the implant, the standard 1 rod removal. The implant removal for 2 rods is basically the same. And this comes from the 20 essential resources on implant removal. This was curated just recently by several of us in the task force. And we compiled and weaned down all of the resources, the wonderful resources that are available, and put them into the 20 essentials. So it took quite a bit of time and work to look through them all, gather the evidence, and then put them into a nice resource package. I'm going to stop there. I hope that some of my colleagues are going to be able to answer some of the questions that I can't answer, but I'm thrilled, and thank you very much for indulging me and ability to share some of the knowledge that we've gained. Thanks.
Thank you very much, Dr. Mark. So now we have Dr. Sarah, who will be taking us into the clinical aspects of contraceptive implants. Over to you, Dr.
Hello, my name is Sarah Prager, and I'm speaking today about contraceptive implants. I have a disclosure that I am a trainer for Nexplanon, but I do not receive any honoraria for this. I'm going to be speaking about 2 different contraceptive implants, the Nexplanon or Implanon Next, and also the Jadel. The mechanism of action of both of these implants is primarily to inhibit ovulation. Secondarily, they both increase viscosity of the cervical mucus and decrease tubal motility. There are some potential interactions for both of these implants, basically the same as for progestin-only pills. And it is wise to avoid potent inducers of hepatic enzymes like barbiturates, griseofulvin, anti-seizure medications, and St. John's wort. When should an implant be inserted? Well, if there has been no preceding hormonal contraception used in the past month, then on days 1 through 5 of the menstrual cycle is the best time. If switching from combination hormonal methods, then anytime within 7 days of the last active combined dose. If switching from a progestin-only method, any day when switching from progestin-only pills, do not skip any doses. Same day as an implant or an intrauterine system removal, a levonorgestrel IUD removal, and on the same day when the next contraceptive injection would be due. You can also place an implant within 5 days following an abortion or between weeks 3 and 4 following childbirth, per the WHO guidelines. Per the US medical eligibility criteria, you can place an implant anytime following childbirth. After medication abortion, implants can actually be placed right away, as early as the same day as the misoprostol. In a study looking at 2,288 women in 22 Ethiopian health facilities who had medication abortion, many of whom also had implants placed the same day as their misoprostol, the overall success rate with a mifepristone and misoprostol regimen was 96.8%, showing that there is basically no effect when placing the implant same day as giving the misoprostol. And a backup method is not needed if the insertion occurs as recommended. However, if deviating from the recommended timing of insertion, first rule out pregnancy and use a backup non-hormonal method like a condom for 7 days after the implant was inserted. There are potential side effects of the implants. There could be pain at insertion site, which can just be treated with ice or NSAIDs or Tylenol. Rarely an infection at the insertion site, which can be treated with antibiotics, and implant removal if an abscess forms. And implants definitely can cause bleeding irregularities, and that bleeding can be irregular and unpredictable. The total amount of bleeding and number of spotting days is similar to or slightly better than a normally menstruating woman. It just might be irregular or unpredictable. We do see stable hematocrits over 3 years of use, and specifically with the Implanon, we see more amenorrhea after 2 years than we did with Norplant. Almost anyone is a candidate for an implant. Women who want a highly effective method of birth control that requires thought only once every 3 to 5 years, women who have contraindications to estrogen use, women who are recently postpartum or who are exclusively breastfeeding. There are some contraindications per the WHO medical eligibility criteria, certainly known or suspected pregnancy. And then current breast cancer is a category 4, meaning do not use. History of breast cancer is a category 3, meaning the risks may outweigh the benefits. Current ischemic heart disease is a category 3, and a history of ischemic heart disease is a category 2, which means that the benefits outweigh the risks. Migraine with aura is a 3. Severe cirrhosis or hepatocellular adenoma or malignant hepatoma is a 3. Unevaluated or unexplained vaginal bleeding is also a 3. And hypersensitivity to any of the components would be a contraindication. There are some data about non-contraceptive benefits as well. The progestin implant can actually improve endometriosis. In one study, it was equivalent to Depo-Provera at reducing pain. 41 women were randomized either to Depo-Provera or the implant, and their pain was evaluated at 6 months with a visual analog scale. The pain was decreased 68% with the implant and 53% with the Depo-Provera. And bleeding rates and overall satisfaction was similar. This is a small study, but it indicates that implants can be used to help with endometriosis. The data for implants and ovarian cysts are a bit more mixed. They do not decrease the risk of ovarian cysts over baseline. The etonogestrel implant was looked at in a study versus a levonorgestrel implant versus the copper T380A, and they were evaluated at 3, 6, and 12 months. The 12-month cyst rate for the etonogestrel implant users was 26.7%. In the levonorgestrel implant users, which is the Jadel, was 14.6%, and it was 1.2% in the copper IUD users. Let's move on to the Nexplanon, which is the etonogestrel implant. This implant is a single rod system. It is 4 centimeters long and 2 millimeters wide. At its core, it has an ethylene vinyl acetate mixed with etonogestrel and also now some barium sulfate. That is what makes this different from the Implanon. There is a rate controlling membrane that is made entirely of the ethylene vinyl acetate. And the release rate is initially 60 micrograms per day. And then it decreases over time to 25 to 30 micrograms per day by the end of the 3rd year. The Jadel, on the other hand, is a 2-rod system, and these have a copolymer core with levonorgestrel, and then a thin-walled silicone tubing and silicone adhesive at the ends. It is slightly longer and slightly wider than the Nexplanon implant as well. And the way that these are placed, instead of with an inserter, is with a separate trocar that is shown here. Prior to either implant insertion, the site must be prepped with an antiseptic and then inject approximately 2 cc's of 1% lidocaine along the planned insertion canal or canals just under the skin. With the Nexplanon placement, we have an updated insertion protocol to try to reduce the number of deeply placed or malplaced implants, specifically with the Nexplanon. We like to have the patient supine with her arm up and behind her head, as shown in this picture on the far left. Then, approximately 8 to 10 centimeters above the medial epicondyle of the elbow, find the sulcus between the biceps and triceps muscle, and then locate an area approximately 3 to 5 centimeters inferior to that, and that will be the insertion site, as is identified here in this central picture. This avoids the sulcus, where there are lots of important nerves and arteries and veins, as indicated here in this picture. The top image here is of a Nexplanon inserter, and the bottom image indicates how the implant is placed. The inserter trocar goes just under the skin at a 30-degree angle, and then the angle is changed to parallel, and slightly tenting the skin is advanced until the trocar is completely not visible, and then the implant is released into that subcutaneous space. Jadel insertion is slightly more complicated. The area for insertion is pretty much exactly the same as with the Nexplanon. However, the trocar is inserted first after the antiseptic and the anesthesia has been placed. And it is placed with the bevel up and the plunger in and advanced until the skin is at the mark closest to the hub. Then the plunger is removed and the first implant is loaded, and the trocar is then pulled back, holding the plunger steady, so the implant is laid into the subcutaneous space. When the trocar is pulled back to the most proximal mark, then the direction is changed, it is repositioned and re-advanced to create that V location. The new implant is loaded, and then the second implant is left in place just as before. After insertion, it is important to verify that the implant or implants are present by palpation, and both you as a provider and the patient should palpate the implants. Then place an adhesive bandage and a sterile pressure dressing over the insertion site. Stitches or even steri strips after insertion are not necessary. The implants should be removed after 3 to 5 years of use with the Nexplanon and after 5 years of use with the Jadel, or when pregnancy is desired, when switching to a different method of contraception, or just when the patient wants, if they are no longer satisfied with that method. Extended use of the Nexplanon has lots of evidence to support it. In one study of 311 women who extended past 3 years, 204 had completed 5 years, and there were no pregnancies in years 3 through 5. In a separate study of 291 users who were followed up to 5 years, there were no documented pregnancies during years 3 to 5 over 444 woman years. That study also included 50% of the subjects with a BMI greater than 30, and those patients also showed etonogestrel levels above the threshold for ovulation suppression for women in all BMI classes. So being overweight or obese is not a contraindication for using the Nexplanon or for using the Nexplanon in an extended manner. Nexplanon removal includes the following steps. First, locate the implant by palpation and mark the end closest to the elbow. Apply the antiseptic to the removal site. Inject a small amount of lidocaine, half a cc to possibly 1 cc, just under the end of the implant with a very small amount just under the skin, so it's not painful. Make a 2 to 3 millimeter longitudinal incision over the implant end in the orientation of the implant. Then push on the proximal end of the implant towards the incision and score through that fibrous capsule until the implant pops out. Grasp and remove with forceps if necessary, but often it won't be necessary. If that implant is in the proper location, then a new implant can be placed to that same incision at that same time. However, if the removed implant was in the sulcus, then do not replace in the sulcus and move to the 3 to 5 centimeters inferior to the sulcus for the new placement. Afterwards, apply again an adhesive bandage and a sterile pressure dressing. This is just to show some images of locating the Nexplanon. If it can't be felt, then X-ray or ultrasound can be used. The Nexplanon is radio opaque. And then if you have capabilities of sending a serum etonogestrel level, that certainly can be done. But etonogestrel levels, which are often undetectable within 1 week after removal, are often very difficult to obtain. And Dr. Farid will be talking much more about challenging removals. Jadel removal is almost entirely the same. The primary difference is that instead of a longitudinal incision along the length of the implant, since there is a V of 2 different implants, make the incision at the distal base, a horizontal incision at the distal base of the implants, usually 3 to 5 millimeters, and then again, push the implants one at a time towards that incision, score through the fibrous capsule, and remove the implants one at a time. A new Jadel can also be placed at that time if desired. Thank you very much. That's my brief review, and the other presenters will also give their data now. Thank you.
Now we're going to have the next presentation by Dr. Farid. But before we go there, if you have any questions, if you have anything that you want to share as a concern, please feel free to get into the chat box or drop it at the question and answer. So our participants and also our presenters can feel free, and we'll be responding to your questions afterwards. And all the recordings are going to be shared later by the institution, St. Paul's Institution for Reproductive Health and Rights website. And we've put the website at the chat box. Feel free, and it will be available within a few days after the finalization of this webinar. So thank you very much, Dr. Sarah, again, and over to Dr. Farid.
Good morning, good afternoon, good evening, wherever you are. So in the next few minutes, I will be taking you into the clinical approach to difficult implant removals. I have no financial disclosure or conflict of interest to declare regarding the materials discussed in this presentation. So this is going to be the outline of my presentation. We will see the rationale for implant removals, possible causes of difficult removals, the diagnostic approach we follow, and the removal procedure steps that we have. So as a rationale, ensuring access to implant removals is an essential component of high quality service, as Mark mentioned earlier. It affects the public trust on the entire family planning program, or at least the implant specifically. And most difficult removals are due to difficulty in localizing the implant. In other words, non-palpable implants. In cases where the implants are palpable, removal is usually a routine procedure, and that can be done very quickly, taking about less than for about 4 minutes. But when the implants are non-palpable, the procedure can be complicated and can result in iatrogenic neurovascular injuries. It's estimated that non-palpable implants are rare, occurring about 1 per 1,000 insertions. With increased uptake of implants, it is conceivable that we will more likely encounter this rare complication. And if removals are attempted without caution, then we are likely to face complications that are related to the procedure, which can have significant morbidity and mortality. A few case reports have identified severe neurovascular injuries that has resulted in the need for surgical corrections. So in this publication, that there was a traumatic pseudoaneurysm during attempted removal of subdermal contraceptive implant. There is also another publication on peripheral nerve injury where a patient sustained injury to the ulnar nerve. As you can see on the picture, the initial incision was way far from where the actual next plan was placed. So it is essential that we have a good understanding of the approach that we take when we are dealing with difficult implants. So one of the things that we should always consider is what are the possible causes that will result in difficult implants, removal implants. So it is always essential that we anticipate the cases that might have difficulty in removal. And most of these are related to inability to localize the implant, or where the implants are actually non-palpable before removal. So the possible cause of non-palpable implants can be deep insertion, where the implant is under normal circumstances, the placement should be subdermal. But in this case, where it is deeper to the subcutaneous tissue or to the fascia or inside the muscle. So the other thing is insertion at different size. So before we say that the implant is non-palpable or non-existent, we have to make sure that it was actually inserted in the appropriate sites. We need to consider that implants are actually inserted in the non-dominant hand of clients, and that is not always necessary the left hand. So we have to consider where the actual insertion was done. So the other possibility is migration. Usually migration happens within the arm. Usually it happens within 2 centimeters in the cephalate direction, but there are some rare case reports where the implant was actually migrated to the pulmonary arteries in the chest. Since the introduction of the implant device in 1998 and up to 2019, about 107 cases of implant migration into the lung and in the pulmonary vasculature have been reported. The other is non-insertion and expulsion. Yes, or one of the prerequisites at the time of insertion is that the provider should check that the implant device is actually loaded into the inserted device. Otherwise, sometimes non-insertion can happen. And these clients usually visit facilities due to unintended pregnancies. In fact, one of the commonest causes of presumed implant failure is non-insertion. So what are the diagnostic approaches that we should take? One is the careful planning and meticulous evaluation of clients. This is very essential to optimize outcome and prevent complications that can be associated with removal procedure. And whenever a provider faced with non-palpable implants, we have to consider 3 locations. So it's just like a retail business: location, location, location. So what is the location? The first location we are talking about. The first location is location of the facility. So what we mean by this is there a trained provider that can actually work up the client and perform the removal procedure? And that facility have the essential medical commodities to aid localization, including ultrasound device and other removing devices that are essential for safe procedure. The other locations that we should consider is location of the implant within the arm, okay, or in other words, the proximity to neurovascular structures, or is there a distant migration of the implant to other organs. The other thing which actually in fact determines is location of the procedure, okay? So this is location of the procedure within the facility. Is this procedure going to be done in the outpatient setting, in the office setting, or is there a need to transfer the patient to the operating theater or do the procedure in inpatient basis? So basically, it is the ABC of history taking, physical examination, and essential imaging investigations that we should do. Regarding the history, we have to ask the type of implant provided. It can give us a clue to the diagnostic evaluations that we should do next. For example, if someone is having an older form of the implant device where the device is not radiopaque, then the investigations that we will consider is a bit different than when we have the device that is next plan on, which is radiopaque. And again, duration since insertion. We occasionally see clients that have the insertion done years back, like 6-7 years back, and they still present with the previous non-radiopaque version of the implant device. And the site of insertion. So the right arm versus the left arm. Yes, most clients have the insertion on the non-dominant hand, which in most cases is going to be the left arm, but occasionally we see clients that have the implant device on the right arm because they are actually left-handed. So it's essential that we ask the site of insertion before we do any kind of investigation or procedure. The other thing is the insertion circumstances. What were the situations when the insertion was done? Was there any difficulty? Was there any severe pain? Was there paresthesia at the time of insertion? This can also give us clues as to estimate what kind of complications we can anticipate at the time of removal procedure. And the other thing is whether the client was able to palpate the implant immediately after the insertion. This is also important because basically at the time of insertion, we tell clients and we show them how to palpate their own implant device in the arm. The other is whether a prior removal attempt. This can significantly affect the procedure. Clients who had multiple removal attempts can have significant distortion of the anatomy, and this can result in difficult implant removals. So regarding the physical examination, we start by palpating at the insertion site, which usually is identified by the scar during the insertion. So we thoroughly palpate the area, and we also palpate around the groove between the biceps and triceps. Again, this is based on previous recommendations where the device was inserted in the groove between the biceps and triceps, which in most settings still may be the practice unless the insertion technique is updated. This will be followed by thorough palpation of the entire upper arm if the implant device is not palpated. So we will have to palpate the entire upper arm, starting from the epicondyles and proceed to the axilla in systematic fashion. If still not palpated, then we have to pay attention to the contralateral arm and again approach in the same systematic fashion. If there is again significant edema or induration from a recent removal attempt, it's wise to consider postponing the evaluation and appoint the client to come back within 2 to 4 weeks. So the next diagnostic approach is ultrasonography imaging modalities, and ultrasonography is by far the imaging modality of choice, irrespective of the type of implant. In most reviews, it's about 90 to 99% effective in localizing the implant device. Again, it doesn't matter whether the implant device is radio-opaque or not. So it is preferable to use a linear array transducer, the one that is usually used in musculoskeletal imagings, and we prefer to have an ultrasound with a higher frequency, about 15 megahertz. We prefer to put the patient on supine position, and the elbow is flexed at about 90 degree and externally rotated, so that we will be able to scan the entire length of the upper arm where the implant is likely to be situated. So in the next few slides, I will show you the actual procedure that we practiced with imaging and removal of the implant device. So we start the imaging with the probe in a transverse plane, and it will be we will hold the probe perpendicular to the presumed implant location, and this has to be done without significant compression of the tissue, and if there is in fact compression of the tissue, it can significantly underestimate the depth of the device. So it's critical not to apply significant pressure during imaging. So what we are actually looking for is echogenic spot, and this spot will have a posterior acoustic shadow. So as you can see, there is some echogenic spot that will be reflected from the implant device, and there will be a posterior acoustic shadow that will just follow the implant device. It's very difficult to see the actual length of the implant. Sometimes we will have to rotate the probe to 90 degrees to measure the entire length of the implant device, but that section of imaging may be difficult, and it may have a lot of artifacts with the fascia and other structures. So it's easier to identify the echogenic spot followed by the posterior acoustic shadow. So we will assess the location of both ends of the implant, both from the skin surface and from the muscle fascia, if it is found to be below the muscle fascia. For example, in this case, the implant device is about 0.05 centimeter from the skin surface, and it is below the fascia, and it can be clearly seen with posterior acoustic shadow. So we will do the measurement, and we will apply a Doppler to assess proximity to nearby vasculature. So this is very essential in avoiding iatrogenic injury to the neurovascular bundle that are running through the groove between the biceps and triceps. So once we have done that, the next step is to do mapping of the ends of the implant on the skin. So we can use, as you can see on the video, we can use our pinpointed markers to actually localize the implant while scanning at the same time. So upper arm X-ray, again, this is for cases where the implant is known to be a radio-opaque and it is not seen on ultrasound, and it can, sometimes guide us for further ultrasound imaging. If initial ultrasound imaging could not localize the implant device, we can do X-ray, and the imaging of the X-ray, we can have it at hand and guide our ultrasound imaging. And it's always wise to obtain two views, anterior, posterior, and lateral views of X-ray should be obtained. And it's very important to understand X-ray is used only to confirm the presence of the implant, and it does not indicate malposition or depth of the insertion. Common mistakes that we usually observe is that the X-ray reading will come and they say where the implant is found very deep to the subcutaneous tissue close to the bone. So as you can see on this image, this X-ray was initially reported that the implant devices was very deep and close to the bone, but X-ray cannot give you that such 3D image. So it's important to know that the implant device is there, but it doesn't give you the actual depth or proximity to the bone or other structures. So chest imaging, so sometimes it is wise to consider chest X-ray or chest CT scan. Again, this is where upper arm ultrasound and X-ray was not able to localize the implant device, and there is a possibility of suspected migration of the implant device into the pulmonary vasculature or to the chest. So again, this is for implants that are known to be radio-opaque, and in cases where we cannot localize it on ultrasound and X-ray. So as you can see from this report, this patient had the implant that was dislodged into the lung pulmonary vasculature, and based on this report, in fact, the initial imaging reading did not identify the implant device, and it is on subsequent reading and a review by a more experienced radiographer that the implant was actually identified on the X-ray. And as you can see, CT scan can have a more clear picture of the implant device on the chest cavity. Again, another case report where the implant device is barely visible on X-ray, but CT scan showed a much clearer image of the implant device. The same is true here. There is a migration of the contraceptive implant to the pulmonary artery. It's very difficult to actually see the implant device on X-ray, but it will require a very experienced radiologist to identify this implant device on chest X-ray, but CT scan may have a better and a more clear image than just a simple chest X-ray. MRI of the upper arm or chest, again, since the older non-opaque implant device is no longer being provided, the need for MRI is not going to be much frequent. But in the past, or in cases where a client is present for evaluation and the implant device is suspected to be the older implant on device, then MRI should be considered in case where ultrasound did not pick it up. So regarding the removal procedures, a rule of thumb is if the implant cannot be palpated, do not attempt to remove it unless until the implant device is localized by imaging. There is attempting removal should be avoided. In most cases, removal can be performed under local anesthesia in outpatient settings, but in cases where the implant device is deep and close to the vascular structures, there needs to be a consideration of removing this implant device in the operation theater with a multidisciplinary approach with a vascular surgeon, orthopedic surgeon, or any care providers that may have a better experience in delineating the anatomy of the neurovascular structure. So again, in this next few slides, we will be showing you the actual removal procedure that we perform in our clinic. So the steps that we follow is antiseptic preparation of the site, followed by covering with a fenestrated drip, and we will provide a local anesthesia with about 2 to 3 ml of 1% lidocaine. And once the area is anesthetized, we will go for making about 5 to 10 millimeter longitudinal skin incision. This will be followed by a blunt dissection of the subcutaneous tissue with mosquito forceps, And in case where we're dealing with a subfascial implant device, the blunt dissection will continue until we reach the level of the fascia, and the fascia will be grasped by 2 forceps, and it will be opened longitudinally by sharp dissection. Otherwise, the whole procedure will be done with blunt dissection, and only the fascia will be opened by sharp dissection. Once the fascia is opened, the implant device is grasped with a modified vasectomy clamp, and it is brought to the skin surface. Any tissue capsule that is surrounding the implant device is dissected by blunt or sharp dissection. Once the implant device is removed, we will have to make sure that it is complete and intact, and no remaining implant device is left inside. So sometimes, the implant device may fracture and some fragments may remain inside it. So we have to measure the implant device. So in case of the next Planon device, we expect the device to be around 4 centimeters. In case you are dealing with Jadel, we expect it to be about 4.3 centimeters. Once we are sure the implant device is completely removed, we close the incision site in 1 or 2 layers using absorbable sutures, and we offer the client with oral analgesics, and we also inform her instructions when to return and any complications that may arise, and the signs and symptoms of complications that she should follow in case this happens. So this is a brief algorithm that we use in our clinic to aid the localization and removal of non-palpable implants. As we said earlier, our initial imaging modality that we use is linear transducer array of ultrasound imaging of the upper arm. Once, if the device is localized, then we will go straight forward to removal and ascertaining that complete removal has been done. If the initial ultrasound evaluation is not successful, then we have to consider, are we dealing with the older implant device or the more radiopaque, the more recent radiopaque device, or Jadel. In that case, upper arm X-ray will be done, and this upper arm X-ray can be used to aid in repeating the ultrasound localization of the implant. And once the implant is relocalized with the ultrasound imaging, then we will do removal as discussed earlier. In cases where just upper arm X-ray was not successful in localizing the implant, we will proceed with just X-ray followed by just CT scan. So this is what I have. If you have any questions, you are welcome. Thank you.
Thank you very much, Dr. Farid. So the floor is now open for a discussion. We have lots of questions that have already here. Some of the questions have already been taken by our panelists, but I would still bring some of the questions for our discussion. So the first one is around policies and what has been done around trainings when it comes to implants, especially at a government level. So I think Dr. Farid wants to respond on this, plus so you can proceed.
Okay, thank you very much. Regarding expanding the number of or the cadre of healthcare providers, at least in Ethiopia, as Mark mentioned earlier, now a wide range of healthcare providers are providing implants, both in tertiary and remote service. So at the moment in Ethiopia, implant insertion and removal services are provided by mid-level healthcare providers in primary and secondary healthcare facilities. At the same time, there are ongoing trainings to ensure health extension workers have the capacity to do the insertion, or at least link clients who are intending to use implants to the nearby healthcare facility. So tremendous effort has been done, and it seems that is paying off. Okay, thank you.
Thank you very much, Dr. Farid. Another thing that came is around how is the practice? Like, how often do we see difficult removals? Whom are we consulting? Is it always to be done by OBGYNs, family practitioners, family medicine? Like, who's really in the in the removal of difficult removal? What's your experience? We can hear it both from Dr. Sarah and also from the team in here.
What I would say in general is that for any type of healthcare worker, if they are not sure about the location, don't start making incisions in the arm and trying to remove, because that actually can make it more challenging than in the future for it to be removed. So for a health extension worker or an OBGYN, if they are not confident that the implant is palpable, it's preferred, if at all possible, to at least get that initial X-ray to see whether the implant is located there in the arm or not. And then again, if possible, to refer to a higher level healthcare facility with somebody who might have access then to an ultrasound or some means of locating and removing the implant. So that would be my recommendation. I don't have a great number on how many of those implants are challenging to remove. Dr. Mark reported some data on patients who are having difficulty getting their implants removed, but the majority of those are not due to deep implants or, actual challenging removals, but finding a provider who is able and willing just to do the removal. And we do see that there is some challenge with reproductive coercion and healthcare workers, physicians who might feel that the patient should continue to use a method, even if the patient is wanting more children or not liking the implant and just wanting it removed. So I want to make sure that we're not conflating those two issues together. Those are two separate issues, and we don't have excellent data right now on actually how many deep implants there are. And I see Dr. Mark maybe wants to say something, and I'm sure Dr. Farid does too.
I just want to add a quick comment, because I agree with you wholeheartedly. And one thing to remember is the best removal starts with a really, really great insertion. So the more we get our colleagues to place implants properly from the get-go is really, really important. That makes for much easier removals years later. And it's very, very easy to become cavalier and push an implant in too deep if you're not conscious, you're not thinking about it each time you place an implant. So it's very, very important to make sure that we're training people and making sure that we're refreshing on good placement to begin with. And then I agree wholeheartedly, if you don't feel confident, and many providers learned how to place implants and learned the removal skills, but then they didn't ever get a removal for maybe 2-3 years after they had their initial training. And so those folks are feeling less confident. They may have gotten trained initially, but they're not feeling confident on removals, and they should probably either get a refresher or refer on to somebody that they know and trust that can remove an implant. Thanks.
Thank you so much, Dr. Mark and Dr. Sarah. Anything you want to add?
I think probably with the number of difficult removals, particularly where they should be removed, and in settings, especially in global south, where the opportunity of getting highly trained provider is limited, there has to be some creative way to ensure that women still have access to such services. So based on the publications that we see, at least from the Western world, such patients are getting care from highly trained people who have undergone through fellowship training in family planning, in conjunction with people who have skill in vascular surgery, orthopedic surgery, or specifically dedicated peripheral nerve surgery. That will be a bit difficult to ensure in developing countries. So a few centers in sub-Saharan Africa have reported their experience in terms of managing non-palpable implants. So, for example, one center in South Africa had physicians who are specifically trained for removal of deeply inserted implants. So they managed to do more than 99% of their cases without the need to do, advanced surgery or referral to very highly specialized centers. So it all matters into the kind of training that we provide to address the need for difficult removals. As Mark and Sarah said, as long as insertions are made properly, removals are very easy, an average of 4 minutes procedure. So that has to be kept in mind always. So one thing also related with the number of cases of since the new insertion, let me rephrase that, since the new inserter. So for us, we just moved from the older implanon to the next planon just a few years back. The national guideline have not updated the insertion technique, but we're still using the older insertion technique into the groove between biceps and triceps. So we see quite a good number of cases. So I wouldn't be able to give a specific number whether the new inserter have decreased the rate of deep insertion, because we still see cases that come for removal of non-palpable implants, and quite a good number are inserted with the new inserter. Over to you.
Thank you, Dr. Farid. So another thing that came exactly around here is around where exactly insertion should be continued. Like there are controversies around, should we continue with parallel? Do we continue with the V-shape? Which one should we proceed? Which one should we use? I have seen Dr. Sarah already started to respond on this, but anything you want to add to the public, Dr. Sarah?
Can you clarify what exactly you want me to expand on?
No, like using the V or a parallel insertion when it comes to the implants.
Yeah, so I see Dr. Mark has also responded on that. I think the sulcus, both of us, I think, mentioned this. The sulcus was originally chosen because it was sort of thought, since there was that kind of divot in the muscles, that we could, hide the implant in that space a little better. And in retrospect, that was kind of a bad idea, because there's lots of important structures in that space, nerves and vessels. And we believe now that those rare cases of implants migrating in vessels, et cetera, and getting into pulmonary vasculature happen because of the location of all those important structures right in that groove. So that's why the company now is recommending that the placement actually be over the triceps muscle, so 3 to 5 centimeters inferior to that groove. And I don't believe that Jadel has formally made that different recommendation. It certainly is fine to also use that new location for Jadel. However, we also believe that there are many fewer misplacements of the jadel because they're in the V location. And so they're just simply not going, there's not as much likelihood that they are going to be placed into a vessel or to have such problematic placement or to travel in the same way that sometimes the single rod implant can. I also wanted to clarify one other thing. In my slide, I mentioned that the WHO recommends a delay after birth before placing the implant, and that actually was an old recommendation. So thank you for whomever corrected me. The current recommendations now are actually a category 1 for women who are not breastfeeding and a category 2 for those who are breastfeeding to place immediately, essentially. So they now are aligned with what the United States MEC are. So thank you for that correction.
Thank you so much, Dr. Sarah. Another question that came is around availability of spouses and involvement of spouses in increasing access to implants. Any comments and experience around involvement of partners and how to really involve partners in increasing access of implants? Dr. Farid?
So I think it's a good question, very relevant in our setting. But the point is, we always encourage couple counseling and couple joint decision making. But at the end of the day, the final decision will be, what the woman wants. So if the preference of the woman is to have her partner during the counseling session, during the actual provision session, then it's well and good. That's something that we encourage. But at the end of the day, if she wants to make the decision by herself, then this is something that we are going to respect, and we are going to provide the service that she is intending in visiting for. Over to you.
Thank you so much, Dr. Farid. I think most of the questions have already been responded. If there is anything I'm missing, Dr. Sarah, I'll first give to Dr. Mark. Anything that you want to add or clarify or a message to our participants?
I'm not sure I have anything to clarify about that involving the spouse or spouses. It's incredibly complicated and it varies tremendously within countries, regions, cultural context. I've heard many, many women say, I need to consult with my partner, my husband, and others say, hey, it's my decision. I can decide whatever I want. So that range is huge. And, I agree, it's really fantastic to have couples be able to talk to each other and discuss their contraceptive needs and desires. And yet we know that that doesn't always happen in a very safe environment or unsafe environment, I should say. So it's incredibly complex and varies tremendously from all over the globe. So
thank you so much, Dr. Mark. You are right, it has been one of the controversial areas, but as Dr. Farid and you has clearly said, we still give and respect women's rights, and also not just women's rights, but all who come to us for contraceptive services. So it's one of the areas that needs more clarification, and thank you for taking the question, and also participants for raising such an issue. So thank you very much, our participants. Doctor, I will give a round of chance for all our panelists. I'll start with Dr. Farid. If there are any key messages that you want to take.
Okay, so thank you all for participating on this webinar. I think it was a very successful and fruitful. Just one point that I would like to make is with the new updated insertion site for next planner. So yes, there is a new update to put the device on posterior to the sulcus over the triceps muscle, but this has not been updated nationwide in our country, at least. So the message I want to pass is we don't want a single provider or an institution to go ahead and start a new insertion technique, because we know some women who have the insertion at some place will go for removal to another place. So we don't want them, like someone who is going to remove will be looking for the device on the initial side. So it will create a mess. So if an update is have to happen, it needs to be a system-wise and nation-wise updating the training manual. That's what I want to pass. Thank you very much. Over to you.
Thank you, Dr. Farid. Dr. Sarah, over to you for a key message.
Hi, thanks. I guess my key messages are, I have two key messages. The first is that the majority of the time when the implant is placed, it's going to be perfectly placed and easy to remove. So even though we're talking about challenging removals in part here, that is really the minority of removals. Most of the time, it's very simple to remove these implants. So I don't want providers to be discouraged from using the implant because of a fear of removals. I guess the second part of that message is, again, to emphasize what I said before, that if you do encounter a difficult removal, use the modalities for location, et cetera, and the techniques for removal that Dr. Farid mentioned, because these actually work really, really well. And if you have access to the ultrasound, et cetera, with just a little practice, you really can get very skilled at this. And, I would say 2-3 years ago, when I spent the year at St. Paul's, we were doing, I don't know, maybe 5 or 10 of these that year. And now I feel like you're doing, I don't know, 10 plus a month, maybe more, Farid can say. And I think part of this is that, that those numbers of women that Dr. Mark was mentioning who have been waiting to get their implant removed are now able to do that because the providers at St. Paul's are now so skilled at doing this. So it takes a little bit of practice, but it actually is very doable for OBGYNs. And occasionally we have other specialists like orthopedic surgeons who can help if need be. We certainly use that in the United States at times. And but most of the time, that's not going to be necessary.
Thank you very much.
Thank you all for participating.
Thank you very much, Dr. Sarah. Dr. Mark, for a final key message.
Thanks so much for this opportunity. And just a quick segue from what Sarah and Dr. Farid had said, the difficult removals should be rare, and it has so much to do with great insertions to begin with. So keep aware, keep doing great insertions. Easy, simple insertions lead to easy, simple removals. I'll also put in a plug for the resources that I mentioned. There's some nice resources, and they're very similar to what Farid showed in terms of a video clip. There's also some nice resources in there on how to develop some training and skills using a linear probe ultrasound, using a turkey leg or a chicken leg that has some similar tissue to what the arm might. And you can learn quite a bit about how to find the acoustic shadows of implants with a linear probe ultrasound in that. And there's also some good clips as well, just very similar to the ones you just showed. Fantastic. Really, really great stuff you guys are doing. So thanks so much for allowing me to participate.
Thank you very much, Dr. Mark. And I want to take this opportunity to thank St. Paul's Institute for Reproductive Health and Rights for arranging this SRH lecture series and webinar. And it's a very good opportunity for us to collaborate, to get together, and also to learn from each other. And this webinar series was hosted with St. Paul's Institute for Reproductive Health and Rights, together with St. Paul's Millennium Medical College. And thank you very much, our participants, and also our panelists, Dr. Sarah, Dr. Mark, Dr. Farid, for taking the time and presenting on this very important topic, implants, from where we are when it comes to programmatic aspect, when it comes to how we are on clinical practices, and also how to really take care of difficult cases, including difficult removals. And it's a very important area that we still continue to update each other, because we are still continuing with this practice. And as one of the rights that women and girls should be getting the chance to be benefiting from in scientific advances, we really look forward to see what we would see next when it comes to the next version of implants, and what would be the next part of implants that we'll see in this world. So thank you very much, our participants and our panelists, and we finalize our webinar today. Thank you.